So my first question was what your views are on risk stratification.
I mean, I think for me, it's about understanding who's at risk, I guess, within the practice profile, and then actually what you can do about that. So I think it's, I suppose, depending on how you set the parameters within that risk stratification, it's about identifying a cohort that needs that extra intervention or focus on their care, and then actually really understanding what you might do to support that.
Yeah, I mean, for me, I think it's being able to be proactive. So identifying patients that will need a bigger or a larger care package going forward, and how we can proactively provide that before the patient gets to a point that it becomes A, more expensive, and B, outside of general practice.
And I think for me, I think about that proactive word. I think that's important. And I suppose thinking more broadly about using population health tools, in one sense, risk stratification is one element of that. And I guess I always like to dive into the words a bit. And so when we talk about risk, quite often we're talking about a risk of high cost care and what that might be, but there can be other risks, really just a risk in a decline in people's well-being or decline in their independence, whatever those particular things may be. I think quite often, in my view, the tools kind of are helpful. Quite often it throws up names and people that are known, but it's helpful to collect them into a coherent list. But it will also throw up people who you haven't identified as being at risk and aren't really on people's radar. And I think that's one of the helpful things about it. So we're kind of stratifying risk to identify what sort of services are suitable for which people. And again, I think we're on a journey in Lambeth in doing that. It's one thing working out a package for the people at the high risk end, but working out what the characteristics of people who are perhaps at lower risk, but what will really be helpful to them. It's part of a process that the risk stratification feeds into.
So for you, it's important not just to identify those very high risk patients, but also some of the patients who are further down the list and may have different needs and support. Is that kind of a critical part of risk stratification?
Yeah. Well, yes, I suppose that's why, in a way, I like to not just focus on it as a risk thing, but people who have particular characteristics that you want to address. So I suppose it's partly about identifying which people are suitable for particular pathways, or even more importantly, identifying population groups for whom a new pathway or a modified pathway would be helpful. So also looking at the characteristics of certain subgroups, populations.
Okay, thank you. So as you mentioned, Therese, there's been involved in risk stratification over a number of years, and I just wonder what the drivers were behind starting a new project around this last year.
I mean, I think for me, it was about the development of our primary care networks, actually, and being able to understand much more about the population and what's going on within the population. So really supporting our population health management, as a tool really to support that. And obviously not the only tool to support population health, as Justin said earlier, but I think a way of identifying the common sort of themes across a patient cohort. What is it that's happening? What are the needs? And what can we do differently? What is it we could be doing differently within general practice to support those needs? Done a lot of work, obviously, around coordinated care, and it was a real, for us, quite a large proportion of the commissioner funding is actually spent on care coordination. Actually, how do we make sure that we're, doing that to the right cohorts? We worked a lot with sort of red, amber, green cohorts across Lambeth. How do we make sure that we're identifying the right patients within the right cohorts, and then putting the right services in place to be able to support those patients? So for me, it was kind of the link with the care coordination, but then obviously the bringing in the primary care networks. How do we make it that we can look at a primary care network and think about what other services we might have within that primary care network that supports that risk stratification? So not just general practice, but community services, voluntary sector, etc.
I think also we wanted as primary care to be getting ourselves into a good position to lead on some of this work. A lot of partners are doing similar things, and we want to work collaboratively, but it's really helpful to have our own tools to be able to look at that. Although as we discover, it's not always simple. The analytics, as Tom probably knows, well, inevitably knows more about, but it's not always straightforward, and there are challenges in having good data. The old computer adage, rubbish out, rubbish in, applies. So we have reference how we'd like things to be in an ideal world, and part of that is really developing cleaner data to be going in and identifying what's there. But it's they're not always quick wins, I think, but there's such powerful potential in this approach that we need to keep mining away at it.
Well, we do, because we've been working with care coordination for maybe 4 or 5 years, haven't we? Mm-hmm. And you're quite right, the patients that we know that are frequent attenders, we know who they are already, and we still feel like we're not getting the data that we need. So I think it's really important that we do have a tool that can help us move forward. And I think, Justin, what you've said about the, clean data in gives us, some really valuable data out. And I think that's where we are now, really. And we really need to push forward with that. Mm. I think it's going to be really important as well in providing services within our PCNs, within our primary care networks, bringing services closer to home, looking after our patients in the right place. I think a lot of care is provided, it is not the right place for the patient and is not as holistic as it should be. And I think with a good tool that can inform us, we can provide services that are a better place for our patients.
Mm. There's something also I think about just being on the front foot. I don't think we've ever felt we were on the front foot when we're relying on data from commissioners or from other sources. That really doesn't put us on the front foot, and I think that was something we were really keen as a federation to achieve. That we had the sort of the information at our fingertips almost, so that we could share that with our member practices certainly, and then more recently with our primary care networks. I think that's a really key bit for us.
Mm. Yeah, no, I agree. We've always been driven by somebody else's agenda, and care coordination has been about minimising a commissioner's cost, patient cost within secondary care, where we need the data to be able to provide services within our PCN, and it needs to be our agenda around providing better care for our patients.
And the potential on the geography there as well as just seeing how different characteristics are spread through the population. I was just glancing earlier at the I think Dr. Foster did this heat map of COVID vulnerabilities, and there's being able to look at small areas where the clusters of potential problems are, and as Michelle says, that gives you the ability, in theory, to direct services in those areas, but also from the PCN point of view. Where in Lambeth we've got 9 PCNs who there are many similarities, but there are also differences in the different areas, and being able to drill down into what the differences are to support the planning, and again, it's early stages, but having the tools really is a platform to do that and move forward.
Okay. I mean, you touched upon some of the things that would that you need to have there for risk strat to be used in an ideal world, like clean data. Is there anything else that's really important, and also what's important in terms of delivering the importance of risk stratification in terms of delivering primary care today and in the future?
Yeah, so I mean, looking at populations, looking at long-term conditions, identifying case finding, perhaps gaps in service delivery, and how the parameters, by which we are measuring those things. These are all really important ways that we can be, I suppose, delivering population health. That's the phrase, and that's in what I mean. When I was at medical school some time ago, the population health that was on the agenda, and in a way, it's always been a bit of a Cinderella interest for clinicians, but thinking about public health, population health, it's important. It's becoming much more clearly a part of the remit of primary care to be looking after our population, to be key members of the people doing that, and so to be able to lead on that, to have the information, is important. We need to build that infrastructure, and the other thing that we need is that kind of analytics ability, and I suppose the imaginative ways of using data to really inform us well. There's so I think it's really important to be able to, because primary care is a precious resource. I suppose I'm a GP, particularly think about GPs, but all the other professionals in the team need to be directed in the right places to really yield the benefit and have an impact.
Therese?
I think there's an opportunity, to share some of that risk stratification as well, and some of the patient lists as we get into sort of conversations within the primary care network, certainly, really start to share the information with other providers, particularly. So there's a real opportunity to work with our community providers, for example, in looking at are our lists the same lists? So with the housebound, with patients needing more intervention, etc., is there an opportunity to actually share some of the workforce actually to be able to look after those patients as well? It gives us a real opportunity to start to think about how we might share some of that workload. So it's not just about general practice trying to do all the work out of hospital. Actually, there's an opportunity for community and primary care to work together. And actually even have some of the outpatient and other sort of service redesign out and much closer to home. It's just such an opportunity, I think, in being able to share some of that intelligence and that information in a risk stratified way, so that we're not sort of making sort of best guesses on it. Actually, we've got the evidence that supports some of that, and we're confident, I think, to share those lists.
Yeah, and also in relation to looking forward about how we're planning our own services within primary care and patient education. If we know what the real issues are going to be, and if we can see a patient's journey and where those stages are, we can have those interventions and, you know, that education. So maybe we can reverse some of the trends that we see happening now. You know, that, like Justin said, you know, the resource is very thinly spread in primary care. We have to be able to look at our service redesign and working with other providers. You know, Therese, you mentioned community. I can really see primary care and community working together for shared outcomes for patients. That makes absolute sense to me. It makes no sense that the practice nurse sees one patient and the district nurse sees another. You know, we really need to join those services up. But yeah, so that I really see that will inform how we move forward and how we provide care in the future.
Okay, great. What has the engagement with Dr. Foster helped you to do so far?
So we obviously, I think we've obviously had the primary care data as part of the risk stratification tool. So we've been able to look at it from a very sort of primary care lens, I think I'd say. I think the richness now will come with being able to put the SUS data together with the primary care data. And really that gives us our proof of concept, really, which is what we've always wanted to be able to showcase to both other providers, but also our member practices, but also to commissioners as well. I think there's a real opportunity. And I think it's the intelligence within Dr. Foster and being able to sort of sit with us, talk with us, understand what we need, and actually pull together a very sophisticated specification. I think that's been really helpful. But that's been a co-produced, it's been co-produced between us. So it hasn't been a sort of a top-down or something handed to us to agree. Actually, we've talked about, what our specification is over a number of months to actually land something that's co-produced and that we can put together and then sort of see to the end, really. And I think now the next stage is the SUS data going in with the primary care data, which will really, really give us the richness and the the risk stratification tool that we've always wanted, really, to be able to share.
Yeah, it certainly gives an extra kind of level of power to have the secondary care data combined there, and yeah, we that's something to really look forward to and think about how that's going to be used again for the benefit of patients to improve the services.
Yeah, I don't really have anything to add to either of your comments, really. I would totally agree with both of those.
The other thing I'd add is Dr. Foster's been good at identifying members of their team, actually, that are best skilled and able to actually support us with some of this work. So I think we started our discussions with a wide, a lot of people around the table, and I think we've narrowed it down to sort of 2 or 3 key individuals within Dr. Foster that really understood and understand what we wanted and what we needed. And I think that's why we've landed sort of, a good working relationship, but also some really good, 3 really good tools that we'll be able to take forward.
Okay. And how do you think it will benefit you and your service users going forward?
All of the above.
Yeah. Yeah, I think we've covered most things.
Yeah.
For us, it's really about.
I suppose I think one reason why public health or population health it doesn't immediately appeal to a lot of clinicians, I think, because it isn't about a one-to-one relationship with a patient, and if I do this single thing, it will yield a happy, smiling patient. It's more about those broader interventions, the multidisciplinary interventions. But the benefit that comes from that is allowing clinicians to use their clinical knowledge, clinical skills where it's most needed as part of a team. So the risk stratification by itself is an academic exercise. It needs to be part of that whole development of a population health approach. So it's I guess it's important not to see it as a silver bullet that's going to suddenly make everything wonderful, but the potential benefit in terms, as I say, of having the right skills for the right person in the right place, and also by improving the care to the population, reducing some of the burden and workload on people. So it has to be teamed up with useful pathways and the right pathways, but that that can work. And equally for the benefit to patients is there, and being part of that, putting them in touch with things that are really useful to them.
I mean, there's also something about, I think, the progression, isn't there as well? So when we talk about sort of the red, amber, green cohorts, we're really keen to make sure that anybody in a green cohort doesn't end up in the red cohort, and certainly doesn't progress into the amber if we can help it. So it gives us that kind of a tool, I suppose, that gives us that proactiveness that we talked about at the beginning, in being able to do something about it very early on. So, we want to do more with those patients in the green cohort, so that we can see the benefits later on. Equally, we don't anybody in the amber that may stray into the red. We want to try and stop that as well. And these patients are fairly poorly as it is, with 3 or more LTCs. It gives some complexity to them anyway. Actually, how do we prevent that getting even worse for them, so that they've got a better outcome and a better quality of life?
I know we're out of time. I just wondered if I could ask you just one other quick question. And how you see the role of social prescribing within risk stratification as a particular intervention. Is that something that is important to you, and would it become more important going forward?
Yeah, I mean, I was going to say, actually, building primary care is developing their teams. We have different skill sets now, so the risk stratification is really important about ensuring that our patients see the right clinician who has the right skills. And I think that social prescribers have a very important role within primary care. We've seen the benefit of that over the last 3 or 4 months within our own PCN and practice. And I think that risk stratification will improve that.
Yeah, so I think when I talk about the risk stratification being a part of the whole picture, and having different responses for different people, I think social prescribing is a really key part of that. And in Lambeth, we've got a IT system which will be another part of the jigsaw, I think, that helps with that, which won't just help, but helps in terms of referrals, helps in terms of kind of tracking referrals, tracking outcomes, and even, I mean, potentially, which is also part of our whole response across the community, with community partners being involved, we can feed into that. But so that it's such a complex system, but the IT allows that to actually to manage a complex system, which without it you can't do. And I mean, Therese referred earlier about the red, amber, green cohorts we've got, and tracking people, and I think that's not just on an individual basis, but looking at how we're doing, which is a long-term project really. How are we doing in terms of any prevention work that we're putting in? Is it having an impact on preventing an increase in people's risk?
But also, I suppose, how do we use because we've got that intelligence now with the risk stratification tool, how do we use the social prescribing link workers, for example, employed by Age UK in Lambeth, but working with the primary care networks? How do we give them the intelligence to be able to use some of that to actually support some of those patients? And actually, some of it might be about signposting them to voluntary sector or wherever to support their care. And it's not necessarily that from a health aspect, but more about that social inclusion. It may be a knitting club, it may be a gardening club, whatever it is. There's just an opportunity to be able to identify those individuals that would benefit from some of that, and just a different way of looking at how their life is improved or their quality of life is improved on a day-to-day basis.